So I would like to welcome you to this major session, which is titled Towards the Elimination of Viral Hepatitis C. It's really encouraging to see that during the conference there's a lot of attention for viral hepatitis this year. We also had a pre-conference on Saturday just dedicated to hepatitis C, or hepatitis B and C actually. I would like to pay tribute to the original owners of the land, and I'm Annette Verster. I work at the World Health Organization at the Department of HIV, Viral Hepatitis and STIs, and the focus of my work is on key populations, so marginalized populations at increased risk of these infectious diseases, which includes people who use drugs and people in prisons. So you may be aware that the World Health Organization launched a strategy towards the elimination of viral hepatitis some time ago. And there are very clear targets and indicators. And also we continue to issue, we have already issued and we continue to issue guidelines for countries on how to achieve this. Harm reduction is a central part of the strategy, and also there are very clear targets towards, for example, needle syringe programs, and also we're starting to develop targets for opioid agonist therapy, maintenance therapy. Today, we have 4 outstanding speakers in this session: Lisa Maher and Tom Wright from Australia, Margaret Bourke from Ireland, and Danil Nikitin from Kyrgyzstan. Each speaker has between 10 and 12 minutes to present their paper, and then at the end of all the speakers we will have about half an hour for discussion, question and answers. This session is also virtual, so there will also be perhaps comments or questions from the audience that joined us virtually. So I think we can start. So I would like to invite Professor Lisa Maher, who is program head at the Kirby Institute for Infection and Immunity. She's professor in the Faculty of Medicine at the University of New South Wales in Sydney. And I'm not sure I know the acronym, what it stands for, NHMRC.
National Health and Medical Research Council.
Thank you. So there she's a research fellow, an honorary research fellow at the Burnett Institute, also here in Melbourne. She has extensive experience in research, program development, and service delivery in North America, Southeast Asia, Australia, and the Pacific. Her research focuses on preventing infectious disease in key populations. The title of her presentation is Incidence of Primary Hepatitis C Infection Among People Who Inject Drugs in Australia, Progress Towards Elimination. Lisa, thank you.
Annette. Thank you, everybody, for coming today. Whoa. Got it. As most people probably know, the prevalence of hepatitis C virus exposure, so seroprevalence antibody, is pretty high in Australia among people who inject drugs. And prior to the availability of direct-acting antivirals, only 1% to 2% of Australian people who inject drugs were treated annually due to the horrible interferon. But the therapeutic landscape in Australia was transformed in March 2016 when these new drugs were listed on the PBS, so access for all adults with no restriction on disease stage or ongoing substance use or provider type. So we demonstrated in a paper a few years back that people who inject drugs in Australia are willing to initiate treatment when you have these drugs available, and we provided the first population-level evidence of a decline in viremic prevalence in this group, so hepatitis C virus RNA. And here you can see the decline from 2015, so the pre-DAA period, 43% with active virus, and 2017, the first year of the post-DAA period, 25% with active infection. Actually, that's just another way of showing the same thing, but you can see the treatment uptake increasing over time there. So the aim of this study was consistent with trying to look at whether we'd met the GHS strategy targets on viral hepatitis, which the 2031 was to reduce new hepatitis C infections by 80%. But then there was a sort of sub-target to get to 30% by 2020. So the current study aimed to estimate primary incident infection among a national sample of people who inject drugs before and after the introduction of the access to the new therapies on the PBS. So the Australian Needle and Syringe Program Survey is conducted annually throughout Australia at about 50 Sentinel Needle and Syringe Program sites. We invite people to participate by completing a brief self-administered questionnaire and providing a capillary dried blood spot for HIV and hepatitis C testing. The primary outcome of the study was hepatitis C seroconversion, so defined as a negative HCV antibody test followed by a positive antibody result, and we used the person years method to estimate the time to primary incident infection. We used a simple deterministic linkage to identify people who were repeat survey respondents and to create two separate retrospective cohorts of antibody negative respondents that corresponded to those two time periods, so pre and post DAA. The risk of primary infection was assessed using unadjusted and adjusted Cox proportional hazards regression models with 95% confidence intervals, and also showed demographic characteristics, drug use behaviour, and other health-related characteristics that were assessed as having changed were included as covariates in the model, and we obviously had appropriate ethics approval. So among 757 people who inject drugs, more than half were male, the majority were heterosexual, the median age was 40 years, and the main drugs last injected included heroin, pharmaceutical opioids, and methamphetamines. A total of 97 and 41 seroconversions were identified, indicating that primary hepatitis C incidence more than halved, from 13.6 per 100 person years to 5.4 per 100 person years in the post-DAA period. The Kaplan-Meier survival curves, which I'll show you in a minute, both overall and stratified by age, drug last injected, opioid agonist therapy, Aboriginal and Torres Strait Islander background, and receptive sharing of syringes were used to estimate the probability of primary infection. And the decline that we observed was independent of any differences in drug use and demographic characteristics over the time period. In adjusted analyses, primary hepatitis C incidence was significantly lower in the post-DAA period among those aged less than 45 years, those who last injected methamphetamine, those retained in OAT, people who did not identify as Aboriginal and Torres Strait Islanders, and those who did not report receptive syringe sharing at any period. And so here you can see the decline from 13.6 per 100 person years to 5.4. So that is equivalent to a 58% reduction in hepatitis C incidence between those two periods with the introduction of those drugs. Tables. Okay, and here's our survival curve, so estimating pre and post DAA therapy. It's pretty impressive. So our finding of a 53% reduction in primary incident infection among people who inject drugs following the widespread availability of those direct-acting antiviral therapies and a corresponding decline in viremic prevalence adds to the evidence that Australia met the GHSS impact sub-target of a 30% reduction in incident HCV infection by 2020. I'd also just note that Australia surpassed the 2030 syringe coverage target, which requires annual distribution of 300 sterile needles and syringes per person who injects drugs, more than a decade ago. However, while the incidence of primary infection has declined substantially among people who inject drugs in the years following the DAA scale-up in Australia, prevention coverage remains suboptimal in some populations. Notably, significant reductions were not observed among younger people, those who last injected opioids, those not retained in OAT, Aboriginal and Torres Strait Islander respondents, and those who reported recent receptive syringe sharing. Although the effect of DAA treatment scale-up may have been limited by sample size in some of these subpopulations, our findings suggest that tailored hepatitis C virus prevention, diagnosis and treatment initiatives targeting young people and those from an Aboriginal and Torres Strait Islander background are needed. However, we did observe a significant reduction in primary incidence among respondents who were retained in OAT, suggesting that strategies to enhance retention in OAT, such as reducing the out-of-pocket costs and ensuring continuity of OAT following release from prison, are also needed. Bunch of limitations around generalisability, because these are people who actually attend needle and syringe programs. But we do know that Australia's network, there's about 900 government-funded NSPs, and they distribute the vast majority of syringes that go out in this country. We didn't include reinfection. This is a kind of data issue that we're looking at going forward. But that means that we may have underestimated the incidence of all hepatitis C infections, particularly in the post-DAA time period, where we know that reinfection is happening. And we may have, missed some people that were able to be linked, potentially due to incomplete data, the use of aliases, nicknames, or changes in family names. So we met the 2020 sub-target of a 30% decline in new infections, but we need to try harder. In order to achieve the 2030 target of an 80% reduction, we need to optimise widespread and equitable access to prevention, diagnosis and treatment. And we need to intensify our efforts among subpopulations where significant reductions in primary incidence have not been observed, such as young people, Aboriginal and Torres Strait Islander people, and those not in OAT. And our findings also demonstrate the utility of linkage with these serial cross-sectional surveys and using these data to monitor progress towards global and local level impact targets. I'd just like to acknowledge the traditional owners or custodians of the land on which this conference is taking place, everybody, participants and staff and managers at NSPs and people who inject drugs who participate in surveys, our colleagues at the State Reference Laboratory at St Vincent's in Sydney, our National Advisory Group, the Australian Government Department of Health for funding this survey since 1995, and Greg Dorr has some research grants to declare, and this work has now been published in Addiction. Thank you.
Lisa, thank you very much. That was some amazing results from Australia, already reaching the targets set by the Global Health Sector Strategy in 2020, which were set for 2025 and 2030. Really incredible. But we can discuss after at the end of the presentations. Thank you, Lisa. So our next speaker is Dr. Margaret Bourke. She is a general practitioner in Dublin, Ireland. She's worked in HSE addiction services since 1994, developing services and treating patients. Since 2017, Dr. Bourke has worked under auspices of the Hepatitis C treatment program, treating viral hepatitis in opioid substitution treatment settings. The title of Dr. Bourke's presentation is Maintaining Hepatitis C Micro-Elimination Through Times of Crisis, COVID Pandemic, Beneficiaries of Temporary Protection, and People Seeking International Protection. Thank you, Margaret.
Thank you.
The floor is yours.
Okay, the HSE services in Ireland provide free opiate substitution treatment and hepatitis C treatment for anyone who requires it. Our health service is divided into 9 community health organisations, and we work in CHO7, which encompasses both a city and rural communities. The population in the area where we work is 674,000, and the number of opioid agonist treatment patients is 4,033. We provide services within community general practice, which links with our central services in addiction treatment clinics and satellite clinics. We also link with the prisons and hospitals to continue treatment while people are either in custody or in hospital and then on their exit from these. We provide hepatitis C treatment within our addiction treatment services clinic, but this can be for also patients in community practice. All hepatitis C treatment is provided by myself, the GP coordinator, and a specialist hepatology nurse, and the pharmacists working in the clinics. All persons entering OAT in our service are screened for HIV, hepatitis C and hepatitis B. And all those who are hepatitis C PCR positive are referred to the hepatitis C treating team, which is effectively both myself and Gail, the nurse with whom I work. We investigate with FIB4 blood tests, renal investigation, alpha-fetoprotein, platelets and coagulation screen. We also do FibroScan. Following our national guidelines, and in some cases with the guidance of the National Clinic lead to hepatitis C, we treat all hepatitis C cases except those co-infected with HIV or with decompensated liver disease. Prior to the pandemic, we had treated 197 patients with direct-acting antiviral medication and obtained a 99% sustained viral response. To date, we have now treated 311 people. Ireland has had one of the largest COVID lockdowns in Europe, with 2 major lockdowns and varying levels of restrictions from March 2020 to March 2021. During the period, we continued with face-to-face consultation and treatment in our addiction clinics. Measures were put in place to make services as safe as possible to protect both patients and staff. During the first year of the pandemic, 613 persons applied to enter the addiction clinics in CHO7 for OAT and were prioritised into treatment. New OAT guidelines were developed and new legislation introduced to facilitate prescribing, not always on site. Non-applicants have had no not previously linked with services, and 50% were homeless, living on the streets or in temporary transient accommodation. The opportunity to test for hepatitis C and treat if necessary all new entrants to opioid agonist treatment was prioritised, especially since we felt many of these would fall away, but actually most of these people have remained in treatment with us. 40 patients of 6.2% of those who presented for OAT tested HCV PCR positive. Treatment was dispensed on site at our OAT clinics, and all patients are treated with Maher or Epclusa at first-time treatment, or with one or either of these medications, or Vosevi if it is a retreatment. 35 patients were treated with a DAA for 8 to 12 weeks, depending on the medication, regardless of continued drug or alcohol use. 100% SVR was achieved. A patient with 4 patients with decompensated cirrhosis were referred to the local hospital hepatology service. 3 have completed treatment, 1 is outstanding but linked to services, and 1 patient disengaged. During travel restrictions, if people were COVID positive, but only 1% actually of those who presented became COVID positive. But medication was delivered if patients were isolated, delivered by our outreach team using a risk-assessed delivery service which had been developed. The transit hub for the refugee and asylum seekers is in the catchment of one of our large addiction treatment clinics. We were contacted by the clinical management of the hub when it became apparent there was a need for addiction treatment, and a referral pathway was established. The first patient was referred to us at the end of May 2022. We have had 60 referrals from this source, all requiring OAT. 8 Ukrainian persons, 5 male, 3 female, and 55 Georgian, all male. The Ukrainian cohort had some referral information from their country of origin, and those who were HIV positive actually arrived with the 3-month supply of their antiretroviral therapy. The incidence of HIV in persons on OAT in Ukraine is 59%, and in the cohort who presented, 4 were HIV positive. 3 Ukrainian patients remain in our care, 2 of whom are co-infected and were referred to an infectious diseases service, and their hepatitis C treatment has been provided there. 1 patient who was only infected with hepatitis C was treated by us and achieved SVR. 5 persons were transferred to live elsewhere and within the country, and appropriate treatment was arranged for them local to their place of residence. And 2 were HIV positive and were transferred to an OAT service with access to an ID clinic, and 3 were HIV negative and their hepatitis C status was unknown. We had no opportunity to test as they were transferred very quickly. The incidence of hepatitis C in Georgia in the general population is 5.9%, and 18 patients disengaged who were referred to as disengaged very early from treatment and were not tested. 11 screened hepatitis C antibody negative, 8 screened PCR positive. 5 were treatment naive, and 2 were previously treated and failed to achieve SPR. 1 PCR positive patient was lost to treatment. 17 screened antibody positive PCR negative, of whom 13 reported treatment in Georgia and 4 apparently self-cleared. 6 recent referrals are currently processing for treatment, for testing and treatment. Those 2 patients who were provided with retreatment were treated with Fosevi. 1 has completed treatment and had a nil viral load on completion of treatment but awaits SVR. 1 is currently completing treatment, and both were treated with Fosevi. 1 patient, as I said, achieved SVR, and 1 PCR positive patient was lost to treatment as he was transferred to another area of the country where we were unable to obtain services for him. The challenges we encountered where communication was very difficult due to language barrier. We used Google Translate and translation services. History was difficult to obtain as patients were not forthcoming. We had no information from the country of origin for the Georgian patients, and the patients were also very suspicious of us as we are, in their eyes, a state agency, and despite being assured of medical confidentiality, they were still not able to trust us fully. That has improved enormously. Transfer to other areas of Ireland is a problem, and some patients disengaged from treatment for various reasons. The model of care is a patient-centred approach providing DAA treatment in conjunction with OAT. As I've said, this treatment is provided by myself and a specialist hepatology nurse, with the dispensing in the clinic by the pharmacist. This approach ensures optimum adherence and achieves high SVR rates. Psychosocial supports are an integral element of our care and are provided where possible. And safe injecting advice and referral to needle exchange is provided for those who require it. Thank you.
Thank you very much, Dr. Margaret Bourke, for this overview of the Irish model of care on providing hepatitis C testing and treatment alongside or inside opioid agonist maintenance therapy. Thank you very much. So our next speaker, I'm sorry, I have to reopen my computer. The next speaker is Danil Nikitin from Kyrgyzstan. He has been representing the Global Health Research Center of Central Asia since 2007 and headed the Global Research Institute, the Glory Foundation, since 2011. Danil earned a master's in social work from Columbia in 2006, and prior to this, he worked with Osh Regional Narcological Center as a program administrator. Danil's research focuses on substance use, HIV, gender-based violence, overdose, and hepatitis C virus prevention in drug-using communities. The title of Danil's presentation is Feasibility of HCV-Specific Self-Testing, Brief Interventions and Referral to Treatment as a Model for Effective Linkage to Care of Persons who Live with Hepatitis C and Inject Drugs in Kyrgyzstan. Danil, the floor is yours.
Annette. Hello. I would like to present an overview of the community-based care model that we applied while piloting in Kyrgyzstan the HCV self-testing in people who use drugs. We designed this model with consideration of the values and preferences regarding self-testing that we researched collaboratively with the community-based harm reduction network. We acknowledge the traditional custodians of the land on which the conference is taking place. We are extremely grateful to the Harm Reduction International and other sponsors and organizers of this conference for their support and provided opportunity to present our work. The project was generously sponsored by FINE, Global Alliance for Diagnostics. We in Kyrgyzstan would like to thank Ms. Angel Shilton, Dr. Yelena Ivanova-Raypolt, and Dr. Guillermo Martinez-Perez of FINE, who have been generously sharing their time, experiences, and energy for providing methodological supervision to us. We all know that people all over the world will benefit from the products and services that will be developed using the data, the knowledge that we've been generating. We are grateful to all project beneficiaries for their responsiveness and willingness to participate in the project. Now, a few words about the project context. In 2021, the Kyrgyz Harm Reduction Network and Glory Foundation partnered with FINE, Global Alliance for Diagnostics, to conduct a rapid qualitative assessment of values and preferences of HCV self-testing among people who inject drugs in Kyrgyzstan. This partnership then expanded to a study on the feasibility of implementing HCV self-testing among people who inject drugs in the context of risk reduction provided by community-based organizations. In December 2021 through March 2022, in Bishkek, 100 people took part in the pilot study of the acceptability and feasibility of HCV self-testing among people who inject drugs. The participants were people who inject drugs no younger than 18 years old, of any gender identity, able to understand the scope of the study and provide written informed consent. They were not aware of their HCV serology status. In other words, they never tested for HCV or tested HCV negative in the most recent test performed no later than 12 months before enrollment. The project design was pretty much straightforward. Trained case managers screened and enrolled study participants consecutively as they presented at the study site. Eligible individuals were provided consent for participation in the study. Consent for participation in the study were offered an option to perform or a quick HCV self-test. Study participants were provided written and pictorial instructions and performed the test in a private room after a study assistant demonstrated how to use the OraQuick HCV self-test. Study participants interpreted results and HCV self-tests were handed to a staff member blinded to self-reported results for rereading. Both results were documented and used to determine inter-reader concordance. The study staff captured any errors happening during the testing procedure using a standardized checklist. Acceptability and preferences of HCV self-testing were explored through a brief interview using a semi-structured questionnaire. After the administration of the questionnaire, the participants were tested by a healthcare worker using the professional OraQuick HCV rapid antibody test. Results of testing conducted by the healthcare worker were compared to the self-test results and were used to measure inter-operator concordance. All participants who self-tested positive and were tested positive by the rapid antibody test were navigated by peer staff to a referral laboratory for confirmatory HCV testing. At the laboratory, testing results were communicated to participants. Participants who received a positive result were linked to care following the HCV-Specific screening, brief intervention, and referral to treatment framework. This is what we call HCV-SBIRT, that was integrated into the existing linkage to care algorithm. Before starting fieldwork, we screened and mapped laboratories and medical clinics that could potentially be involved in referral procedures and chose the most appropriate. To monitor the HCV-SBIRT activity's effectiveness, apply needed modifications, and plan for technical assistance, online anonymous surveys were administered. The surveys were carried out in 2 time points: after the participants proceeded with the confirmatory laboratory-based testing, and 1 month after they started treatment with direct-acting antiviral medications. After communicating the self-test and professional test results to the participants, the research assistants conducted screening designed with consideration of the values and preferences for hepatitis C self-testing and some SARS screening and treatment of viral hepatitis in people with substance use disorders advisory. Also using the forms built on the evidence-based NIDA screening and assessment tools and a SBIRT step-by-step guide by Massachusetts Department of Public Health. The original materials were translated and adapted with input from the engaged outreach workers, peer navigators, and case managers, using the algorithm applied by the team while adapting the WINGS SBIRT in 2014-2016. The SBIRT model that we piloted included such elements as screening, the 8-step brief intervention, and referral to confirmatory testing and follow-up treatment and care. The goal of the screening was to identify the client's drug and alcohol misuse status, concerns and possible barriers that would potentially restrict the participants' access to confirmatory HCV testing and, if needed, to treatment. Screening was followed by a brief 8-step intervention performed in a form of collaborative conversation that enhanced the client's motivation to change their substance misuse behavior and explore the advantages associated with confirmatory HCV testing, follow-up visit to a clinic, and linkage to treatment. The brief intervention included offering advice as well as peer-led education about minimizing risks associated with substance misuse and HCV transmission. The brief intervention protocol included elements related to COVID-19, stigma, child care, and intimate partner violence. For managing referrals to confirmatory testing and treatment, we employed peer navigators who have been effective in scheduling appointments and establishing sufficient communication between participants, laboratory personnel, and physicians. The peer navigators represent the HCV champions who initiated and managed multiple adaptations of the HCV-SBIRT. The lab confirmatory scope included, among other tests, immunofluorescent assay and DNA quantitative test, which confirmed HCV in 27 of 39 participants. All of them were invited and got linked to standard care and treatment paid by the project. All 27 completed treatment and attained sustained virological response that was confirmed by a negative DNA qualitative test in all 27 participants. 30 participants completed the client satisfaction survey after their first visit to the lab. Of the 27 participants who received confirmatory testing and initiated DAA treatment, 23 completed the 1-month follow-up survey. Depending on the participants' context, the brief intervention sessions lasted an average of 20 minutes, range 15 through 43. In their responses to the surveys, the participants appreciated the activities performed as a part of the SBIRT, as well as the outcomes and quality of the services they received. We did not detect any correlation between the length of the SBIRT sessions and the participants' level of satisfaction. As you may see, people 35 to 49 years old prevailed among the participants who completed the anonymous post-lab survey and the 1-month follow-up survey. About 2/3 of the participants who completed the lab-based confirmatory testing and follow-up treatment considered that the SBIRT framework helped them to identify risks of HCV transmission, explore ways to reduce risks of exposure to HCV, think about ways to reduce risks of exposure, about the ways to improve their own and other people's safety, and identify their needs for services and find referrals. Most participants were satisfied with the project after performing HCV self-testing and completing the lab-based confirmatory testing. There were 3 participants who proceeded with the supplemental HIV self-testing and tested positive. Their status was later confirmed by the confirmatory testing, and they were successfully linked to the HIV treatment and care. Designing an HCV-specific SBIRT framework and managing future projects within this framework would make the key components of care cascade work much smoother. Resources needed to implement HCV SBIRT successfully include training, time, private safe space, monitoring and evaluation tools with feasible data management technology, coordinated peer support, and services and leadership commitment. While adapting SBIRT model to the HCV testing and treatment provision context, we were able to reclaim the role of people who inject drugs in contributing to their well-being and safety, and ensure high-quality results of community-led research while deconstructing and challenging the way research is traditionally conducted. I think, and here are the references. Thank you so much.
Thank you so much, Danil, for this interesting, sharing this interesting piece of work in Kyrgyzstan around the self-test and people's values and preferences. Our final speaker today is Thomas Wright. Thomas is a harm reduction coordinator at Justice Health and Forensic Mental Health Network in Sydney, New South Wales, Australia. Tom won the 2022 Lavinia Crookes Emerging Leaders Award in viral hepatitis for work in the justice and correctional health sector. Tom has extensive experience working on harm reduction programs in the community and developing and implementing harm reduction projects in prison settings. Tom, thank you.
Thank you. I'd just like to start by acknowledging the traditional owners of the lands we're meeting on today and pay my respects to elders past, present and emerging. So this morning I'm just going to present on our observations of ongoing hepatitis C transmission in the prison system in New South Wales and what we think it tells us around the case for stronger harm reduction. So I'll just start by outlining a little bit about the New South Wales custodial system. So there's approximately over 12,000 people in the system at any one time, and unfortunately that's increasing. New South Wales houses or The amount of people in custody in New South Wales is about a third of everyone who's in custody in Australia. We currently have around 30 publicly operated correctional centres, depending on how you count them, and 3 private centres. The private centres in New South Wales are very large, though, and it's important to note that about a third of the custodial population in New South Wales is currently in those private centres. The remand population, there's a very high amount of people, 37% of people are not sentenced, and there's a lot of movements between prisons as well. So on average, a person can move between 4 different prisons in 1 year, and of those released from custody, about 52% return to custody within 2 years. So there's lots of movements between centres and in and out of the system as well. It's really important to look at this context when we look at this presentation. Unfortunately, as it's been pointed out already in this conference, it remains a national crisis and a shame, the rate of the over-incarceration of our First Nations people in this country. So in New South Wales, Aboriginal and Torres Strait Islander people make up about 3% of the population, but represent about 30% of people in the adult custodial system and 51% of young people in custody. The graph also just shows that we're not heading in the right direction when it comes to this. And if you look at the last 10 years, you can really see the gap's been increasing and it's not closing. So that's kind of got to be the priority when we look at reducing harms in the custodial space. I think I'll come back to this later, but that's definitely the sort of priority number 1. Moving on to look at our Hepatitis C program in the New South Wales custodial system, you can see, like many places, we sort of started to upscale treatment from 2016, and we've now provided over 6,000 DEA treatments to people in custody in New South Wales. And at any one time, that represents about a third of all the Hep C treatment being provided in the state. So about a third of the treatments are coming through the custodial system. I'm pretty sure that's pretty similar across other jurisdictions in Australia as well. Key approaches we use are what we call the early detection program. So it's a screening process, and then we've got a nurse-led model of care that involves the sort of pathology workup right to the point of scripting, which is done by our nurse practitioners or our medical officers, and then we run some targeted approaches at prisons. There's also a lot of research that's done in the New South Wales custodial system, particularly by the Kirby Institute. I think it's important to acknowledge the work that's done in the space by the research teams as well. The current testing approaches that are being employed for hepatitis C in the space are dry blood spot testing, point of care testing, and venipuncture, so a mixture of those 3. So moving on to look at our initiation data and our retreatment data, I'm going to talk about hepatitis C reinfections, but I just wanted to take this point to acknowledge that, as has been pointed out by a good colleague of ours recently, it's really important to think about how we use the term reinfection, and often it can be really stigma-laden and be used in a really blameful way as well. So I think it's important we keep the conversation going around how we use that term. So looking at how we monitor retreatment, so all our hepatitis C treatments are sent out to prisons from a centralised pharmacy. We report our treatment numbers via dispensed pharmacy data. And so once a subsequent treatment is provided from pharmacy, we're able to track that as a retreatment. So you can see in the table, as we've scaled up from sort of 2016 to now, the percentage of retreatments as a proportion to our total treatment numbers has increased, and it's kind of hovering around 35% of all treatments we were providing at Justice Health at the moment are for people we've previously provided treatment to. The limitations around the data set are really important as well. It's not linked to any community data, and it's not linked to that third of people who are sitting in the private custodial system. So when we may identify that someone's been treated twice, we're saying that they've been treated twice in the Justice Health public system. They may have been treated in the private system as well. They may have been treated in the community. That's not represented in this data. So just moving on to look at what we've been seeing in terms of reinfections. table is from the Ministry of Health in New South Wales, and the orange bars represent our initiation numbers, and the smaller brown bars represent the number of retreatments we've been providing due to reinfections. So if you look at the last 3 months of 2022, we provided about 271 courses of DAAs, and about 63 of those were due to reinfections occurring. So, over that 3 months, about 20 a month were being identified as reinfections that needed another course of treatment. So in total, we've confirmed over 900 reinfections, and we've been able to identify that about a third of those, about 300, have occurred in the prison system. So the transmission event has happened in a New South Wales prison. The person hasn't left prison between treatments. The other 2/3, we're not saying they happened in the community, that we're just saying the person moved in and out of custody, and we can't categorically say where the transmission event occurred. And to date, unfortunately, we've also identified 20 people who've experienced multiple transmissions events within one sentence who have acquired hepatitis C twice whilst in a New South Wales prison. Not good data around the proportion of retreatment, hepatitis C retreatments affecting our First Nations people. So when we look at the amount of second treatments, third treatments, fourth treatments and fifth treatments we've provided, for example, we've provided over 1,000 second treatments. 57% of those have been for Aboriginal and Torres Strait Islander people. When we start to look at our fourth or fifth treatments, 75 to 78% of those treatments have been provided to Aboriginal and Torres Strait Islander people. So 60% of all retreatments we've provided due to reinfections have been for Aboriginal and Torres Strait Islander people. I think Lisa touched on this, that I think what the data really tells us is that we really need to focus our efforts on protecting our First Nations people by keeping them out of prison or better protecting them when they're in custody. So moving on to what we think it tells us about harm reductions. For us, the two key gaps in New South Wales, and the priority number one, as discussed, is keeping people out of prison. So looking at the criminalisation of drug use, decriminalisation, justice reinvestment initiatives, and at a minimal, diverting people from the custodial system. The second big gap that's clear for us is the pilot of a needle syringe program in a prison in Australia. This remains really challenging. No jurisdiction in Australia is yet to pilot a prison needle syringe program, despite the very extensive community prison needle syringe program. That's not through a lack of trying. I know there's been a lot of advocacy work, and a lot of people are still working really hard and have been for a long time around this, and I just want to take this opportunity to acknowledge those people who've been doing that work for a long time to try and move that along. Just to touch on the role of opiate agonist therapy, I haven't identified that as a key gap, but neither is it perfect. It's far from perfect. So we've had OAT available in the system since the early 90s for quite a long time. Depo-buprenorphine was introduced via a study in 2018 and 2019, and it's been rapidly scaled up, as you can see in this diagram, the grey line, during the, particularly during the COVID-19 period. This table doesn't go up to where we are now, but currently there's around 1,900 people on OAT in the New South Wales prison system, and that's quite a big increase. So that's close to double what it was pre-COVID. So not quite, but it's come a long way. But there's still big gaps. There's still a big waiting list, and there's still many people who aren't able to access OAT who would like to. There's also challenges around choice in OAT, and there's issues around resources both in the system and when people are released. So it's really important when we're looking at OAT to look at the custodial system and the community system together and make sure they're working well together and are scaled up at the same time. So there's placements both ways for people. And remand and release also, the movement makes it challenging for OAT as well. So I've talked about some of the really big three things, so like decriminalisation, OAT and prison NSP. I just want to move on to talk about a few other initiatives that maybe can be implemented quicker or are still really important. I think that we've found helpful in New South Wales to connect with people who are using drugs in custody or people who've used drugs in the community who have come into prisons. Number one is partnerships with the custodial organisations. We've worked really hard in New South Wales to develop a reference group around harm reduction with the custodial service, and that's allowed us to at least create a dialogue around harm reduction and start to demystify harm reduction and to start to sort of make some recommendations. We've done some reporting and some auditing with them, which has been really helpful. Number 2 and number 3 is about increasing peer access and increasing availability of harm reduction education, which is done with our peer organisation in New South Wales and NUA. We have a very close relationship with NUA, and we've piloted a peer harm reduction program in the system. And Leah, who I know is here, also is the editor of Insiders News magazine, which provides prison-specific harm reduction education to people in prison, and it gets quite a high level of distribution. So most people in the system get a copy of that a couple of times a year. I think as health services, we really need to be playing a role in supporting peers to access their people in closed settings. I think NUA has really taught us a lot about the importance of that and how we can play a role as a service to negotiate access into what is often a really closed space. Number 4, workforce development, particularly with custodial officers. That's a really big priority for us at the moment. We've just created an online learning module for new custodial officers around harm reduction, and so that sort of addresses some misconceptions around harm reduction. It addresses misconceptions about BBVs. It explains OAT, naloxone. It addresses stigma and how stigma affects people who use these drugs, and we're just putting that onto the learning management system for new officers. We're really excited that new officers coming through will be starting to do that training. We're hoping that will start to slowly contribute to changing some conversations. 5th, just having more Aboriginal-led initiatives. We've had a few small pilots in New South Wales that have been led by Adam, our previous Aboriginal Sexual Health and Harm Reduction Project Officer, around Hep C and harm reduction, but we definitely need to do much more work in that space as well. So just by way of conclusion, HCV elimination efforts in prison must be paired with strong harm reduction and prioritise First Nations people. Prison harm reduction projects should be designed and delivered by Aboriginal people and peers with lived experiences. And whilst advocacy for policy reform and equivalence of care in prisons is vital, we also must maximise what we can do to support people who use drugs in closed settings right now. And I'd just like to acknowledge the rest of the population health team, many of whom are here, and also to our partners, particularly NUA, who do a lot of support in this space. Thank you.
Thank you, Tom, for also opening this our eyes to what's happening in prisons in Australia and some really good examples and data. I would like to invite all the speakers to the table, and for you in the audience and also online to think of questions you would like to ask our speakers. And I look also at you for, are there already some, not yet, okay, that's good to know. Right, so thank you all again for your wonderful presentations. We have already a few people here, so let's start with
Okay, I'm
you,
Michael Levy.
Michael, yeah.
Thank you. I've got 2 questions, one to Tom and one to the Chair. Tom, have you offered any treatments in the juvenile justice system?
No, not at this stage.
Now to the Chair. Are there any countries in the world who are reporting their to the goals, the UN goals about eradication, which include prisoner populations? Notably, Lisa's data excludes prisoner populations.
That's a really good point, Michael. I don't really know. It's definitely critical. And I think Australia is certainly an example country. I know Georgia is another country that looks into this. But it's a very good point. Margaret.
Hi. Michael, to answer your question, I'm not aware of any organised reporting of it, but I can ask at a meeting that I'll be at tomorrow night or Wednesday and Thursday night about that. It's not part of the targets, so I don't think that then you've got routine reporting of it. But yeah. So I've got a sort of a kind of a question comment for you. Congratulations again, Tom, for the work in prisons and all that's going on there and elsewhere in Australia, to all the people who are doing that, and also to Lisa and the others. Really interesting. I think Australia's not, and knowing, having just come back from Georgia, and so I don't think we're not atypical in this. There's two bits, and Lisa, I'd be really interested in your thoughts, is people might not be aware, but Australia's treatment numbers have fallen right down. So we're now less than, say, 5,000 treatments, and the models would suggest that that level of treatment is insufficient to keep us on track to achieve elimination. Hard to know what this year's numbers are, but it's looking really dire. And Lisa, I'd be really interested in your thoughts about whether you're seeing that as you look at that drop in incidence, where if you sort of say over the last couple of years, are we flattening off? So that would be the first thing in terms of the data that you're seeing from the Australian Needle and Syringe Program survey. And with that, then also the disproportionate levels of treatment that are having to go on in prisons, Tom, which I think is just an absolute national shame that this is how we're actually achieving some impact, and also with that overrepresentation of Aboriginal and Torres Strait Islanders. And I'm wondering whether there's been any qualitative work that you guys are doing about those reinfection events, because we know we really struggle, and Troy Combo spoke about this on Saturday at the hepatitis session. It's really complex around the issue of harm reduction in Aboriginal community-controlled health services, and just any qualitative work from prisoners that might help us to help ACHISs move that along, that reducing that reinfection event. So I'm throwing those things out to you guys, but I think this has got relevance. I know it has in other locations as well, like Georgia, and other things. So just interested in your thoughts on that.
So we have a question for Lisa, we have a question for Tom. Giten, one more question, and then we go to answer.
Thanks so much. My name is Nikitin. I work with Treaty Asia in Bangkok. I had a question for Dr. Bourke and for Mr. Wright. A couple of questions. First thing, it's really good to hear Dr. Bourke about your work and people who are really struggling to access treatment in a foreign land, and you're providing that as a state service. It's really good to hear that. I also saw your screening for hepatitis B among the patients that are presenting themselves. I wanted to understand if they are, in case surface antigen negative, are they being provided with the vaccination? And if they're surface antigen positive, then are they being linked to care and treatment? I assume you would be doing that, but I wanted a bit more clarity. I understand the session was entirely on hepatitis C, but it would be good to hear for the audience around that. And for Mr. Wright, around, many people in the world and other parts of the world in LMICs don't get to know even the SVR status. So it's get to hear about retreatment because they know the status and they're getting offered for retreatment. 926 odd people confirmed with reinfection, as you say. How do you classify between a reinfection or a treatment failure? What did you use? Was there a genome sequencing that was done? That's the other question for Mr. Wright. Thank you.
Thank you, Gitan. Lisa, do you want to start?
Okay. Thanks, Margaret. I think that, we are going to see a decline in incidence next time we look at that cohort. It's complicated because, and this relates to Michael's question, there's a big overlap between people who participate in the Australian Needle and Syringe Program survey and people who are in prison and out of prison. And unless you do something to fix the prison situation, I mean, this is a large proportion of people who participate in that survey are in and out of prison, so they're exposed to either primary or incident infection, both in prison and in the community. We're doing better in the community. We've got good coverage of needle and syringe programs in the community, but we've got zilch in prison. So we can't expect, I mean, that rate of reinfection in prison is, disgusting and disgraceful. It's a shame. But I totally agree, and it'll be really interesting. I mean, obviously there are some people, with hepatitis C living in the community who are unaware of that, and we are doing, different projects to try and access and identify that group and to encourage uptake. But the easy target is the people who go in and out of prison, and we're not doing anything.
So just the first question around the qualitative data, the short answer is no. I think it is definitely a gap and something we need to look at. There's no formal mechanism at the moment. I know that I understand that Kirby's doing some qual research soon around Sharp-P, so I'm not sure if that will be able to pick up some of the experiences of people who've received multiple treatments through that process. I've spent a lot of time in groups talking to people who've received multiple treatments. I think I'm not trying to say this is a structured qualitative opinion comment, but I think a couple of things that we do notice in people's feedback is we do see particularly people who are coming out of our regional and rural settings seem to be overrepresented and experience less access to hepatitis C services in the community, and that's something they often report back. So quite a few of, I guess, some of the reinfections, though it's definitely occurring in the custodial system, it's important to remember we're talking about people who have contact with the custodial systems, and a lot of those reinfections also are people coming in and out of the custodial system, and when they're in the community, they're not accessing any health care. So they're coming back into the prison, and it's a shame that that's where they're reporting they're accessing their health care. So to the second question, in terms of how the criteria for working through the retreatment, so we do all retreatments go through to our senior clinicians, to our senior nurses, and then they work through a criteria using what's available to them. Previously, we used to get more genotyping done, and they'll use SVR if they have it, but they'll work through a process to make a distinction between, on the available evidence, is it a treatment failure? Is it a clear reinfection? Did someone stop taking their medications? Is there evidence of that? Or is there some other error in terms of pharmacy data or something that is the reason it's come up, or is it too hard to tell? So I'm not a clinician, so I can't give you a real clinical answer, but that's would be my interpretation of that.
Yes, we test all people for hepatitis B and we offer vaccinations. We do not have an incidence of hepatitis B in this cohort of patients since 1982 when there was an outbreak. But for the past 20 years, all people presenting for OAT are provided with vaccination in the prison and outside in addiction treatment services in the community.
Margaret. Kira?
Hi, I'm Kira. I'm working with PATH. Thanks, everybody, for your presentations. Really interesting. I'm particularly interested in your work on our depot buprenorphine in prisons. I'm wondering if you could discuss a little bit around the challenges of choice and what you've learned so far. And also, if you have another word for reinfection. Thanks.
I don't on the second part. Thanks for the question. Look, the depot buprenorphine question's a hard one in terms of choice. So I think the scale-up probably happened really quickly, and it was very much influenced by COVID-19. So there was a reduction. Definitely, when COVID-19 hit the prison system in New South Wales and visits ceased, there was an uptick in people who were no longer accessing substances. There was less substances in the systems because visits weren't coming in, and there was a really increased demand for OAT, and the pilot had just... they'd just finished the pilot, and so it really went very quickly in terms of the scale-up. There is still people who are accessing methadone in the correctional system, but I don't have an easy answer for the question around choice. There's a huge waiting list to access OAT still, even though it's nearly doubled. And so there's kind of population arguments around efficiencies and things like that. But there's problems, as we all know, around individual need for choice. So, yeah, sorry, I don't have a clear answer than that, but it needs more discussion, and at least we're identifying it as an issue that needs to be explored more. And I don't have a better word for reinfection, so if someone does.
Yeah. Can I just say we refer to it as retreatment? I don't know if that's more acceptable.
Is it monthly injectables,
yes.
the depot?
Well,
And you're aware of the work that Adrian Dunlop's leading in New South Wales prisons, which is funded by the health department. Sorry, that study, we're actually going to look at many of those issues, both qualitatively and quantitatively, by following a cohort of people post-release and following them up who are on depot buprenorphine and methadone. Yeah, huge cohort. So that's funded by New South Wales Health. It's a big study, so we will have some data on that. Yeah.
Can I just ask you, before coming to the next speaker, is health in prisons, is the responsibility for health in prisons in Australia under the Ministry of Health or in Ministry of Justice?
It's jurisdictionally based. So in New South Wales, there's a separation between the custodial side of things and health. So Justice Health sits in the same reporting stream as health. So it's separate, but it's different jurisdictionally between the states.
Right. Please. No, it helps, of course, with collecting data. Well, first of all, equity in healthcare, but also in collecting this kind of data.
We do point-of-care testing at medically supervised injecting room for Hep C. Sorry, it's all questions for Tom, but as I understand it, the Hep C treatments are quite expensive, and you can't have unlimited sort of supply to retreatment. Whereas in prisons, it seems to be the biggest issue might be lack of access to sterile injecting equipment. Why? Can you speak to why there is such a reticence to allowing NSPs in the prisoner system? What is the... Because in my mind, it costs a lot more to treat Hep C than it costs to give sterile injecting equipment.
Yeah, sure. I'd love to. No, I think the challenge with it, I think it's one of those areas of harm reduction where, despite how strong the evidence isn't going to win the day on its own in this case. So there's strong moral ideas. There's strong opposition from correctional officers all around Australia. There's unions are very involved in opposing prison needle syringe programs in Australia. So there's people in this room who could speak to this better than I can, but there's a sense of fear and concern and misunderstanding from corrective services officers around it, and so the opposition comes from that side of a security-orientated abstinence-based approach versus a harm reduction approach. But I think Margaret might have something to add.
I was just going to say, you're right. It was born out of a tragic event 15 to 20 years ago where somebody died with an HIV-related injury, and since then it's been nigh on impossible. Sorry? Prison officer. Yeah, prison officer. And since then it's been nigh on impossible to get the prison unions to really come along, despite tremendous and ongoing efforts, but it doesn't mean we should ever give up.
That's right.
Thank you.
Virginia?
Hi. It's a question for anyone, actually, and I'm sorry, I don't know for New South Wales. I probably should know about the time between diagnosis and treatment for people with hepatitis C, and if the policy and the practice is immediate treatment within the prisons and in the community. And also I'm interested for Ireland and Kyrgyzstan as well. Thanks.
So immediate treatment in Australia, Ireland, and Kyrgyzstan?
As long as it takes to do the various investigations, and we then commence treatment. So from receiving the positive test, it's about 2 to 4 weeks for treatment.
Sorry.
Oh, I'm sorry.
At the same time, I can confirm the same time is in Kyrgyzstan, but the data that I presented was just from the pilot project. Now, a larger scale project is going on, and, well, the purchase of the medication is one issue. So, allocating the medical institutions that will be engaged, it is another issue. So, but when all these issues are set and resolved, so then, yeah, the same time period as Margaret mentioned.
It's because of new recommendations that WHO issued around frequency of testing in people with ongoing risk. So every 3 to 6 months is recommended, as well as immediate treatment. Michael.
Some points of clarification from the discussion that's gone on. Prison officer Jeff Pearce, that's his name. He had a name. He was stabbed with a massive bolus of HIV-positive blood, which by any measure was an act of manslaughter, if not murder, and occurred in July 1990. It's one event that occurred and has never been repeated anywhere in the world, and still prison officers in Australia hide behind that, and they glorify this man. Mr. Pearce himself became an advocate for HIV peer education, and those who knew him would be astounded. They speak on his behalf. He's since died, that he's being used as an example for the very thing that could have helped in a different era, he himself. The governance of health services in Australia, in Western Australia, it is the corrective services that still run health services. Here in Victoria, I think Mark could say, but I think it's contracts managed by the public health system, but the service itself is not provided by the public health system. And the rest of Australia, it's pretty much the universal standard of public services, public health services providing health services to prisoners.
Thank you, Michael. Just to say that this issue around needle syringe programs in prisons, that we looked into this in 2006 and 2007. We reviewed all the evidence on HIV at the time, HIV interventions, whether they were feasible in the community as well as in prisons. And this case of this one person who was infected and was stabbed on purpose, as you say, it wasn't an accident, was the only one. And so the recommendation of WHO has been needle syringe programs are feasible and effective in prisons. And the Canadian HIV Legal Network, which is now called the Global HIV Legal Network, they used our guidance to make a case to sue the government, the Canadian government, because someone got infected in prison, because there were no needles, sterile injecting equipment available in prisons, and they actually won that case. So it's a very complicated matter, but I think we need to continue to collect this information, and our latest guidance again makes harm reduction a priority intervention in prisons as well. So I don't know if other countries can come forward maybe where they have been able to implement needle syringe program in prison, but it's literally a handful of countries in the world that do so. Also, Michael, coming back to you about the question around data on hepatitis elimination, whether prisons are included in this. It's a really, really critical point, and I'm reminded of the fact that there is a health in prison project in only one regional office of WHO, in the European office, which includes 58 countries. And of the 58 countries, they did an extensive survey on prison health. So not just infectious diseases, but prison health more generally. And of these 50-something countries, I think only about 20 or 25 countries are able to provide data on prison health. And this is in a region where probably, apart from Australia and maybe some other countries in the West, where you would think that they were maybe more likely to have data. So it is a really important point to continue or to advocate for having good prison health and also having prison health data. And one of the ways to do that is by improving equity and having health ministries take responsibility for prison health, so that the health in prison should have the same standards and the same quality and the same access to the same type of health services inside as outside, as well as the data. Just on the side. I think we can go to the next.
I just wanted to add, Annette, that for people who are interested, at 12:30 there's in room 217 we can continue the discussion on prisons with a special session that's been organised. I think it's in room 217 for an hour and a half.
It's next door.
216, yeah.
Oh, next door. Oh,
yeah.
Great. Thanks.
Hello. Thank you. I've got a couple of questions. If I start with, and I might have missed this, Dimitri, my name's Nick from the Kirkton Road Centre. Dimitri, incentives and anything around the spurt that helped? Were you giving people sort of money or time for their participation?
Well, the treatment was totally 100% paid by the project. Maybe this was one of the key incentives. So all other...
No, it's fine. Just going back to the finger prick, so I'd sort of comment on that one. I get worried around the finger prick that we're only getting a certain amount of clients that like accessing our NSPs. Do you know, we got 350 of them in New South Wales and we're good at accessing those people. But since COVID, we've changed our model a bit with obviously vending machines. I mean, Trevor's got 45 vending machines, so Western and Far Western don't really get a look in terms of, large parts of our population. I suppose I'm just flagging the idea. Have we got any other ideas as to what we can do around trying to sort of find that other tier of sort of something more proactive? I'd love to send people jumping out of the bushes at injecting centres, at vending machines and trying to grab more people, because we're really putting out half of our needles out through that way now.
The first thing to do is to actually, we've got a really nice feedback loop with that data, is to take your site data and compare those characteristics over time to see if the people who are still attending your NSP are the same socio-demographic group or drug use behaviour group that have been attending historically. And if they are different, then that... if they're not the same, then that kind of, will give you an idea that you actually do need to go out there and do that. I haven't tried to recruit clients for service from vending machines, but we years ago kind of, stalked vending machines in southwestern Sydney to try and find young people for a study. And obviously our peer workforce is vital to that. We had peers engaged, people who were able to approach those people in a non-threatening and a safe way. We didn't have a great kind of recruitment rate from that site, because people were, they obviously had their drugs and were getting their needles and in a bit of a hurry to go. So, but
No, they did a test at RPA, Newer, and the Sydney Local Health District did one, and it had some really good information, like 7 minutes, 35 seconds per machine. But it did show that a lot of people weren't accessing our services, and it was really hard to slow it down. So it's just just another one of those thoughts I just sort of go in terms of yields and populations, because we've got in our NSPs we've got huge amounts of people who've been treated with Hep C, and we've educated them, and that's good. I want to sort of move to the next level. The next thing I got was just Tom, I suppose. And I know you, and I know the work that you and Tracy and Colette do, and it's magnificent, and I don't try not to get caught up in the frustration of needles and syringes in prisons. But I noticed in the work that we've done with some of the sort of people and some of the services that are leaving in terms of the halfway houses and where correction ends and where health starts, there's really quite a gap when people leave. And I just wonder if there's some space there that can be worked a little bit in this sector. I mean, people get discharged from prison with $450, 1 week's worth of medication, no housing specifically or some sort of halfway housing, and certainly they're generally struggling to get on some sort of public OAT program because the OAT programs are all full. So I know there's a range of extreme stresses for them. I understand that as soon as they leave as soon as they're discharged high SIA, they now become an LHD issue. And I just don't know if we've reached out enough or we have, because every time I talk to them, the need that they have seems absolutely overwhelming and frightening to us. We can't manage that, if that makes sense. Have you got any thoughts about what we can both do to sort of bridge that gap a bit?
Yeah, thanks for the question, Nick. So I think, yeah, it is a big gap, and I think all the things you have identified are true and a challenge, and people get exited from custody at very short notice, often from court as well, and there's not a lot of pre-planning at all. I think there is a program called Connections in New South Wales that does work with some people pre and post, and I think that there is plans to try and expand that further, so I think that'll be encouraging. There is also some funding available at the moment for community organisations that's been released to tender to support that process a bit as well. So there is a bit of movement in there, but I think just getting some of the basics right is really important as well. And I don't think there's not enough just really clear harm reduction community access points that are made clear to people as they're released. So at least if they're going back to the LHT, they know how to link into people. Doing the referral or link in ahead of time can be really challenging for everyone, but providing some really key information points would be a really good start.
Hi, I'm Leah. I'm from newer and able peer-based organisations. I've got a comment rather than a question. I think, yes, the answer certainly is lying in peer-based services as far as reaching that gap. We know that that's killing it because we don't trust very easily, and the reason for that is that we can't progress this until we look at stigma and discrimination in the general health area, as was talked about this morning. We've just finished a project in Newer around this, and the amount of people who have incredibly difficult times in the health area where the language is wrong, where they're infantilised, where they're not believed, where we're considered to be drug seeking if we've got an issue. I mean, until we really step up all that work around stigma and discrimination, we're not going to be able to access, we're not going to be keen to access this particular area of health. Peer workers do help a lot in bridging that gap, that's for sure. And unfortunately in jail, we have a little bit of freedom from some of the other issues that dog us. Low income, mental health issues, living life under the criminalised system. All those things make it very hard for us to make our health a priority, and until we address those things, we're always going to see this imbalance. Thank you.
Thanks. Thanks.
I would like to add something. Well, about this project. So to provide a treatment for those people, Harm Reduction Network hired one of the best professors in Kyrgyzstan, professor in hepatology. So, I mean, it is really the issue of how they trust, of how they believe in the quality of the people who would ever treat them is very important. Once they decided, just a year ago, they decided to. Well, we found out that there is no clinical guidelines for people using novel psychoactive substances. And Harm Reduction Network, well, they asked me, I helped them a little bit, so they located another good, wonderful professor at the medical academy. They came to her room and asked her to help them, Harm Reduction Network, to develop the country-specific national clinical guidelines for treating, for curing themselves. I mean, this movement, I really appreciate it, and I really like it very much. When people who use drugs develop services for themselves, by themselves, they hire professors. They ask them. I do remember that one of our messages was sent to Paul at Burnett Institute, so he recommended us wonderful clinical guidelines, Australian specific. So we definitely used them well. But this is important. So, and well, so that's it. Sorry.
Danil. One last question. To you, Nikitin.
Very, very quickly. I wanted to just slightly get back because we were talking about immediate treatment or when do we start treatment. We, in India, we tried this on the same day test and treat for people who inject drugs, and it works. And not getting into the data, it took us approximately from antibody to the actual person receiving the first bottle, the median time was 6 hours. And that 6 hours was because of the technology we used, which required a two-step sample extraction process. If we were using a single-step process, it would go down to 4 hours. So that's antibody till actual initiation of the indicator was when the patient actually gets the first bottle, not taking the first tablet. So that actually works. So it could be done in between 4 to 6 hours. We have all the technology in place for hepatitis C to be treated. I think it's mainly around, and COVID has strengthened it very much. We have all kind of DNA, RNA molecular platforms, all kind of chip-based, cartridge-based technology in place. Many countries have strengthened that because of COVID. That's what COVID has brought in good for every one of us, I think. So that's one thing, and it's absolutely doable. And I think it's a matter of some political will and a head of one department or probably a prison setting who is willing to do that. And I'm sure it's done. We have done it first. So the second one is, again, coming back, I would like to note in that one, 88% of people who inject drugs are still susceptible to getting hepatitis B. We provided rapid regimen, 100% compliance. 100% compliance among people who inject drugs. So let's not get into that topic of, whether or not people who inject drugs would comply onto certain medication or vaccination, that they would not. Let's not get into that debate. Let's offer and see, at least with, existing recommendation and guidelines, let's try it out and see whether it's feasible or not. Like people are, it's just, for me, hepatitis B has just been a non-starter. And I wanted to end with this. No, thank you very much.
Very much, Nikitin, to remind us also of hepatitis B vaccination and the rapid regimen. I would like to thank all the speakers for their really interesting contributions. And I would like to thank you all for a lively discussion and comments and questions. And I wish you a really great further conference. Thanks so much.